Thank you so much for this great opportunity. And it's indeed an honor to present our experience from Mizoram, India. A very good afternoon to the chair, esteemed colleagues, and my dear friends. So, Mizoram in India is one of the country's most beautiful yet most challenging state, where we undertook this pilot. So this story is not just about numbers or clinical data. It's about resilience, partnerships, and the determination to bring life-saving services to some of the most vulnerable population in the toughest of terrains. So I declare no conflict of interest here. And talking about Mizoram, Mizoram has a population of over 1 million and has long battled a high burden of drug use. The state has around 15,000 PWIDs, people who inject drugs, concentrated in the capital region and the bordering districts. The hilly terrain, as you can see in the pictures, with porous borders with Myanmar and Bangladesh and difficult road connectivity makes healthcare delivery a really uphill task in the hill station. So landslides during monsoons are quite frequent. There is frequently cut-off roads, delayed transportation of medicines and test kits across the state. And until recently, there was a limited data on actual burden of hepatitis B and C among the PWIDs here. And the secondary research suggested prevalence be around 40 to 50%, but no consolidated programmatic evidences they existed. So with support from the State Hepatitis Control Unit, State AIDS Control Society, the National Viral Hepatitis Control Program of India, FIND and Roche, the donor, we embarked on this mission to integrate hepatitis care into the existing HIV services at the harm reduction sites across the Aizawl district, and made an attempt for micro-elimination in a high prevalence group. So our journey formally began when the government of Mizoram granted approval on 15th June 2023. This was a turning point for us, showing the state's political commitment. And on 3rd of August, we had an official launch of the program. It was a moment of pride for us because the health minister, the highest authority of the state, Dr. R. Lalthingliana, himself, addressed the gathering. He being the doctor himself, as we are hearing since morning, that there should be some doctor in the health system, in the political field to support the hepatitis elimination program. And similarly, we got a lot of political commitment from Mizoram because the health minister was himself a doctor. And he acknowledged that while many stay away from visiting the state during the rainy season due to the landslides, this our project team, had come forward with full commitment. And the event also brought together senior dignitaries from the Mizoram State AIDS Control Society, National Viral Hepatitis Control Program, and other stakeholders. Media coverage also ensured that not only the community is sensitized, but the entire state is being sensitized during the launch. And it was more than a launch, it was a call to action for the entire state. Sorry. So first few days in the field, if I talk about, on day one, we screened 15 PWIDs at a harm reduction site. And to our shock, like all 15, they turned out to be positive. And somehow we, tried to progress ourselves for the day two. And on day two, we screened like 22 PWIDs and all turned positive on day two as well. So we thought that, this can't be true. Maybe the test kits are faulty, but these were the WHO pre-qualified CE marked test kits. And but we still, requested our lab technicians who were doing the actual screening in the field to put control. Usually, we put control one per box of test, but this time we ensured that every day, even if they are using the same test box, they should, put control. The controls, they perfectly confirm that our kits are well functioning and there is no faulty kits. So, we continued screening, and by the end, like, we screened almost like 97% of all PVs that we screened, they turned out to be RDT positive. And that was really shocking news for us and for the state also. We were all in the disbelief and awe that what, we have assumed it to be around 40 to 50% positivity came out to be like 97% RDT positivity. And this realization shaped the urgency of our intervention. And here you can see we had a lot of stakeholders meeting, we had capacity building workshop, we had the launch where the health minister is there, and then we rolled out the screening. So talking about the methodology, our implementation had multiple layers. So one is like screening. All the PWIDs visiting the harm reduction sites or participating in the screening camps, they underwent RDT screening for hepatitis C, as well as we didn't want to miss the chance to screen them for hepatitis B as well. So we did screening for C and B as well. Those who tested positive were given the reflex blood draw, and HCV RNA and HPV DNA confirmatory tests were conducted for all the positives. And also, baseline tests were very important. They're part of our guideline to, put them on treatment. So these non-invasive liver staging APRI and FIB4 calculations are based on these pre-investigations. So they are also performed. All the non-cirrhotic HCV patients with viremia, with confirmed viremia, they were initiated on treatment right at the OST sites, the harm reduction sites, because all the medical and non-medical staff, they were trained on the treatment guidelines, while all the cirrhotic patients and the HBV positive patients, they were referred to the nearest civil hospital for getting them initiated on treatment. And while all this is happening, the community engagement, I would like to emphasize here, it was very important because, peer navigators and the community members, they were involved at every step, to build the trust. And their involvement was critical in motivating the PWIDs to come forward for testing, because stigma and discrimination is very common among these groups. So there were a lot of challenges on the ground. While the methodology looked straightforward on paper, but the reality was very complex. Talking about the terrain and connectivity, Isol's roads are steep and they are very winding. And during monsoon seasons, landslides, they are very common. And on several occasions, our team carrying the blood samples, they were stuck on road for hours. And also, another problem we faced was high cost of baseline investigations. The pre-investigations, which are very important for initiating the patients on treatment, they were very expensive. So, and because they were not really very expensive, but the PWIDs, they were not able to support the cost of those tests. But, after having several rounds of meetings with the state government, we got the prices slashed by half, but still, many of the PWIDs, they were not able to bear the cost of that. Then FIND stepped into, and we covered the cost for all the baseline tests, because the first screening test is free, and the confirmatory was also free, and the treatment was also free, because our government of India, they have test and treat policy since 2018. So, but these pre-investigation costs were the major barrier in between. So we tried to come up with that barrier by covering the cost. And coming to the drug supply, forecasting drug needs was another challenge. With no precise epidemiological data available, the initial demand estimated was based on 40 to 50% of RDT positivity, but it turned out to be like 97%. So all our calculations went haywire. So this led to treatment delay until, the Ministry of Health, they intervened to ensure that the uninterrupted supply of drugs are available. And then community stigma, many PWIDs, they feared being identified or being stigmatized. So peer navigators had to literally, walk with them to the treatment centers to get them initiated on treatment. So despite all these hurdles, the collective determination of the teams, states, central, and implementing partners, it ensured progress. Here you can see the landslide. This is the picture on the way to airport. So many of the times, and this is the kind of road, it gets so mushy when there are rains. So even the 4x4 cars, they are not able to, drive you through these roads. So it's a big challenge. Coming to the care cascade, a total of 504 individuals were screened with 97% of RDT positivity, indicating an extremely high exposure rate. So samples were collected from all the RDT positive individuals, of which like 89% of them, they underwent testing. And among them, 79% they confirmed for HCV RNA, reflecting active infection. And out of 343 confirmed positives, 242, 71% of them initiated on HCV treatment, a strong improvement as compared to the earlier cascade, because bringing the PWIDs again back to care cascade or locating them is another challenge. And of those who started on treatment, 182, 75% of them, they successfully completed it, showing good retention, but still some, they were lost to follow-up. And among 152 eligible for SVR, 101, they completed testing. And of those assessed, 101 achieved the SVR. So 91% is the SVR rate, demonstrating very good rates consistent with the global benchmark. To summarize here, the RDT positivity was really high, and the RNA positivity was also close to 80%. And it confirms a considerable disease burden in the state. And the high prevalence rates were far beyond what anyone in the state and in our team anticipated. So this has implications not only for the Mizoram government, but also for other northeastern states with similar drug use pattern. So what did this teach us? So one is the integration works. So adding hepatitis services to the harm reduction services greatly improved the access. And two, the community trust is very important. Without peer navigators, uptake would have been very minimal. And three, the baseline costs were a barrier. So unless, tests are free of cost, patient will fall through the cracks, because the kind of population that we were reaching out to were not the ones who will be ready to spend on any medical test, but rather they would like to spend that money on scoring the drugs. And lastly, the partnerships drive progress. This was possible only because of the collaboration between the state, central, fine, and the donor. And to conclude, this pilot project in Mizoram demonstrated the feasibility of integrating hepatitis services into the existing harm reduction or HIV services, even in one of India's most difficult terrains, because HIV is a robust program, and HCV is still, in the growing stage. So building our blocks on the already existing robust program was way easy for us. And the extraordinary prevalence highlights the urgency of scaling up the program in the state, sustaining treatment, ensuring adherence, and monitoring for SVR remains the next frontiers. So what started as a small pilot, has now become a model of micro-elimination in action, and one that can inspire and replicate in other high-burden regions across India and also across the globe. We can do that. The words of the health minister, they still, during the launch time, what he said still echoes in our mind, like at the time when no one wants to visit the state because of the rains and the landslide, the FIND team has chose to stand with us. So this shows true commitment from the state as well. And together we have shown that with partnership and the community trust, we can indeed make elimination not just a slogan, but a reality. So we extend our sincere thanks and gratitude to IVHEM and our partners, the National Viral Hepatitis Control Program team, the National Health Mission, Mizoram, and the Mizoram State AIDS Control Society, and also for their invaluable support to this project. And also we are especially grateful to all the project participants for their trust and cooperation. And this initiative has been made possible through funding support from Roche, and the travel was supported by Gilead Sciences. Thank you so much.